Evening, everyone. So, welcome to yet another session in CRD education series, which is focused today on egg and milk and its component, egg and milk allergy and its component. So, just for information, that this webinar is being recorded, and by continuing into this webinar, you are consenting to be photographed, videotaped, live streamed, or otherwise recorded. So by speaking or by writing on chat board, you express your consent, your views to be shared by public at large. And you understand that if you don't want to be recorded, you must avoid speaking or expressing your views. And you also understand that your consent grants us the right to use, reproduce, and distribute your views without compensation and without further notice. And that will release us from any and all claims, if any, arising out of such disclosure. So, with this consent, I would like to call upon Dr. Neeraj Gupta to give us a few words on the session today. To speak a few words on the session today. This is the last session in the series. Dr. Neeraj Gupta, he is IP president and a senior pediatric consultant at Sir Gangaram Hospital. Dr. Neeraj, over to you.
Thank you, Alka. Thank you for the nice introduction. I would like to welcome all of you for this very important, very nice and upcoming series of component testing. We all understand that now we have reached up till a stage in which component testing is really knocking our doors, and we need to really understand it in a very good manner. Then only we will be able to understand all the reports or all the investigations which we are thinking about. So today is the fourth session and the last session. We have already covered our journey through peanut and then dust mite and then pollens and molds. And today is another important session in which we'll be covering about milk and egg components. So what I would like to say that though it is the last session of the webinar series, but actually the journey starts after this. That means we all need to really understand, revise, review, discuss all these components together, and then we will be able to better utilize them for the best, you can say like best outcome of the patient. So I would like to wish best of luck to all of you from IAP Allergy and Applied Immunology chapter. And I am very thankful, highly thankful to Thermo Fisher Scientific for bringing out such a excellent initiative, at least in this part of the world, for component testing. So thank you very much. Back to Alka.
Thank you so much, sir. Now, I would like to call upon Dr. Derrick Varner. He is our speaker for today's session. And his credentials are he is NCCPA certified with 25 years of experience in Texas state license. He has done his BS Radiology RTI from Minot State University and BS and Master's PA Studies from University of Nebraska Medical College. Done his PhD from Trident University International, and his professional experience is like 29 plus years in US Air Force, 25 years family medicine, 9 plus years with Thermo Fisher Scientific. Additional experience in internal medicine, urgent care, aerospace medicine, researcher, clinical coordinator, inter-service, physician assistant program hospitalist. And he is with AAAI Allied Health member. So I would like to call upon Dr. Derrick to take over the session. Mr. Derrick,
All right.
your presentation.
Okay. Thank you. Thank you, Dr. Gupta and Alka, for this opportunity. I just want to welcome everyone and thank you for joining us. We will continue our discussion of precision medicine with allergy immunoassays to support the allergy diagnosis when people or patients present with a suspected history of milk and egg allergy, all aimed at customizing the healthcare. And so this session will be maximize the impact. We want you to consider milk and egg allergy diagnostics with components. So next slide. The next two, we'll get into the objectives. We went over the bio already. And so thank you, Alka, for doing that. So here are our objectives for this evening and today is that there's a growing body of knowledge, as you already know, that demonstrates allergic diseases affect many people of all ages around the globe. And so we notice that there's an increased prevalence and severity and complexity. So in India, milk and egg are among the most food allergies affecting a substantial portion of the pediatric population. But there's good news. There's a new generation of immunoassays aimed at looking at the molecules, which we will review today, looking at some of the current guidelines in the indications of when they appropriately use these component tests with a top-down approach, which is crucial to improving the quality of life and mitigating the risk for our patients. And then lastly, we will put it all together with two case studies to demonstrate how component resolved diagnostics can improve the outcome in patients, not only for the patient, but for the provider and the health system. Next slide. With this being said, as you know, that allergic diseases is growing and it's a major health concern. But before I get into the prevalence of the food allergies in India, I want to give a step back and take a snapshot of give you a landscape what we're dealing with in the Western, in the U.S. And so what we've noticed, and I'm pretty sure that you are experiencing it too, but there's a growing demand for the allergy care and allergy services, where in the US it's like 33 million people that are affected by food allergies. And it was stated that globally it's like 250 million people that may be suffering from food allergies. And so when we look at the prevalence in the US, it's about 8.8%. And when we look at the different populations, it averages about 1 in every 13 children in the US. That averages about two children in each classroom that can be plagued with food allergies, and about 1 out of every 10 adults that may be plagued with food allergies. And we see that this is a growing issue in industrialized countries. And so, as I stated, it's about 250 million people across the globe that may be plagued with this condition. So, next slide. And so, what we'll do, I just want to introduce, and you probably are very familiar with this concept already. It's called the Big Nine. And we know that there's at least 170 foods that have been identified that can trigger food allergy. And most people are affected with one up to three food issues that may be challenged. But the good news is most of these patients may grow out or even develop a tolerance to food allergies. However, there is a certain percentage of these patients that may have lifelong issues with food allergies. So I just wanted to introduce the concept and remind you that the Big Nine, this is where 9 foods account for 90% of the food reactions. So next slide. So looking at the prevalence of food allergies in India, India, what I found out is one of the most diverse countries in the world. And so with that being said, the incidence of food allergies is rising alarmingly. In an article in 2023, it was published in the International Journal of Clinical Biochemistry of Research. It noted the prevalence of allergic disease in India was about 20 to 30% of the total population. And more specifically, with today's topic with milk and egg, the author stated that IgE mediated food affects as many as 6 to 8% of the children and 3 to 40% of the adults in India. Next slide. When we looked at this study was a retrospective study that was conducted at the Global Reference Lab in Mumbai, India from May 2020 to May 22. And it totaled about 65,000 patients. Interestingly, it was like over 52% were female. It was interesting to me that the majority of the allergens were dust and followed by insect allergy, but over 51.78% had food allergies. And in that group, the incidence of food allergies was highest among the group that were 0 to 3 years of age. So this is important because it affects the pediatric population. And despite the many uses of the value of these foods and what we're talking about today, egg allergies were the highest, followed by cow's milk. So that's really relevant to our discussion today. Next slide. So that leads us into what we call, I like to call the diagnostic dilemma, because food allergies, they're unpredictable. The symptoms can range from local reactions to a systemic life-threatening, which often recalls and recommends that we either avoid certain foods, and actually we have to sometimes give an epinephrine for a lot of those patients that have that IgE mediated food allergy. So appropriate diagnosis is therefore vital. It can mean the difference between leading a life that one must consistently be on vigilant, high alert, or it can be one that someone that doesn't have a food allergy can live a little bit more carefree and relaxed. So this brings us to the diagnostic dilemma that we, as physicians and clinicians, we face every day. I will share with the group. There was an article that showed that it was in the U.S. that showed up to like 35% of people do what we call self-report a food allergy. But after appropriate testing, it was revealed that only 3.5% of those patients truly had a food allergy. So testing goes a long way um, uh, with uh, with trying to help manage these patients. The other thing I want to bring out is that it's so important because we need the ability to rule out food allergies. I call that the power of the negative when I can put it all together, because it's just as important in ruling out as it is in ruling in. So, with that being said, we have to understand what is truly a food allergy or a food reaction. So, we have to define it. Food allergies, wide symptoms, but a lot of people think they may have a food allergy when they don't. They may have actual food intolerance. So, when patients present of suspected food allergies, we have to pause and think which bucket or which category do they clinically fit in? Is it immune mediated or is it non immune mediated? Meaning that it's just primarily food intolerance. So, as you know, food allergy is that arises when the immune is responding upon you reintroduce something and you get this response, a negative response, an overactive response. And it usually will happen within minutes or within at least 2 to 4 hours. Now, there's some other categories that fall into that category. When we talk about non-IgE mediated, it could be cell mediated, like celiac or FPIES, that's that food protein induced enterocolitis syndrome, or I like to in this other category where this non-immune mediated. And so there's a host of things. It can be metabolic, where it can be lactose intolerant. It can be pharmacological, where it may be a response to certain caffeines, or it can be from toxins from inappropriately or stored or mishandling of fish, or some other things that may be idiopathic or just simply undefined, like stress. It can be gastric esophageal reflux disease. It could be irritable bowel. It can be some structural things. So we have to be able to rule those things out. And so, with that being said, let's go to the next slide. I want to share with the group that there is some hope. You don't have to do it all by yourself. There are some guidelines, both from the European and also from the Western society, that they actually provide a roadmap. And so this roadmap is both for specialists and for primary care. It provides some strong recommendations and some guidance when it comes to diagnosing and managing food allergies. The recommendations are really based upon strong evidence and best practices that really emphasize we got to take a good detailed history. That's our pre-test probability. With a confirmatory testing, which is our, and we match it up with post-testing probability to really get that clinical diagnosis. And as you can see here, it all starts with the history. History, as I tell my students, is king, right? You got to take that history. So next slide. With that being said, we talk about pretest probability. To aid us in this, the IACI has printed some, this is just one example of some key questions that we must consider. We must ask the patient, when did the manifestation start? Was it in infancy, adolescence? Was it in adulthood? Or where did the symptoms, how did they come on? Was it immediate? Was it delayed? Because as we know, most symptoms, when it's truly IgE mediated, will happen within minutes or up to 2 to 4 hours. And then what was the route of exposure? Was it ingested? Was it inhaled? Was it touch? And then is the patient sensitized to different pollens or latex. So there's a number of questions that we must ask, because with the questions, if you hit the next, just hit return, you'll see that there's this pretest probability that we use with the history taking and with the test results. And then we match those together. So next. And you can see coming up at the bottom right there, when we talk about that pretest probability, is we're basing it upon the history. And we're trying to get an indication, is it a low, is it intermediate, or is it high based upon the history? And then we match it up with the post-test probability when we get those test results back. Is it low, intermediate, or high? And so, for example, we get a history that is low, that is not really convincing, it's not really suggested. We categorize that as low. And then if we were to do some testing and we get those results back and it's negative or it's low and it's just not, or it's even equivocal, then we can put those two together and say it's probably unlikely that it's truly allergy. And you can see the contralateral when we have the same, when there's a high probability, when there's a strong history, and then you get a strong test result, and you can put that together, and you can see that that is definitely in the right upper corner of that graph that is highly allergic. So next. And so that moves us to this when we talk about testing. And I just wanted to remind you that the IACI guidelines is just a strong reminder that it all begins with the history, and doing some type of testing is so important. And so next. So there's two types of testing, as we know, that you can do. You can either do in vitro diagnostic testing or skin prick testing. And I just wanted to share with the group, and you already know this, that both of these tests are tests of sensitization. And so there is strong clinical utility and equivalency when you look at these tests. But the take-home message is you may have sensitization, but the key is, are they clinically having symptoms? Because you can have an elevation quantitatively, and also you can have a skin reaction, but we have to ask ourselves, is it causing any clinical symptoms upon re-exposure? So you can have sensitization, but the patient can be totally asymptomatic. But here are some of the benefits that we have to remember when we're doing in vitro testing. You can do it on any patient. They don't need to be fasting. They can be pregnant. They could be on a plethora of medications like beta blockers. They can be on antihistamine, steroids. You can test them in any season. They can have various skin conditions like dermatographism, eczema, psoriasis, because as you know, you need a patch of skin to test these patients. And the beautiful thing about doing in vitro testing, there is no need for a crash cart. There's no chance of anaphylaxis. And so that's the beautiful thing you can do with in vitro testing. So next slide. And with that being said, I just want to talk about the immunocap technology. Specific IgE blood testing is an established technology that is recommended, both clinically and scientifically tested, that you can trust to confirm the IgE-mediated allergy. The thing about the immunocap within the tube, it is a very unique, has this unique capacity or high capacity with the solid phase technology. Immunocap IgE blood testing is what we call the gold standard. It is validated over 6,000 scientific articles, and it's been IVD in what we call in the United States, the FDA clear quantitative measure of specific IgE. And so with testing, the lab only needs at least 1 milliliter. And as you recall, IgE, the immunoglobulin, is the smallest of the immunoglobulins. So the ability for this technology to capture and to identify and quantify IgE is so significant. It has that cap has the ability, or this high capacity binding technology, to detect extreme low levels of IgE. So next slide. So this next slide is just showing you the graphic representation of the level of IgE concentrations that may correlate to the probability of symptoms. And so at the x-axis, on the x-axis, you can see the concentration of IgE. From the left, it goes all the way up to from 0 to 100. That's the concentration of IgE. And we matched it up with the symptoms. So the higher the symptoms and the higher the level means that there's a high probability or a high likelihood. I want to pause right here because I like to just reiterate this. This is what trips up a lot of primary care providers, is that they think the higher the number means the higher the severity or higher in organ damage. But we have to tell them no. It's just showing that there's a correlation, there's a probability. The higher the number, the higher likelihood. And also, I would like to point out, you can even have a low level but clinically significant symptoms. And I got several examples where the specific IgE level may be only 2, 3, or 4, or 5, right? But when that patient is exposed to that particular allergen, they are severely clinically symptomatic or even anaphylaxis. So I just want to share that with the group. So on the next slide, when we talk about, I want to share with the group, there's something called decision points. Now, these decision points, I would just want to point out, this was done by Hugh Sampson and his colleagues at Mount Sinai in New York in the North Upper East region in the U.S. They conducted the study looking at children and adolescents to determine, to make a decision point, what is the cutoff level that we can safely say a patient will either fail an oral food challenge or either pass or food challenge with a level of confidence. And so, or what will put this patient at risk if we, at what level can we make that determination? And other studies and researchers are really uncovering is really going to be based upon the population that you're in and also the geographic location. It varies. So that leads us to that little gray zone you see. What are we missing? Can we do better to minimize putting these patients at risk when we do oral food challenges? And you can see here just an example. If you look at egg in Hugh Sampson's patient population, we see that 6.0. That shows us that in his patient population, anytime he had the whole egg that was over 6, there was a 95% probability that these patients will fail or fail the oral food challenge. He would not do an oral food challenge if the whole egg was over 6. Now, conversely, if that egg was less than 0.6, him and his colleagues will, with a level of confidence, would probably put this patient through an oral food challenge with a level of confidence, saying that 90% of these patients with that level will pass the oral food challenge. Now, next slide. I want to illustrate this point again on this next slide from the IACI. They did something very similar to illustrate this point. On table 7 in this, the summary, they did a summary of diagnostic performance of certain foods, and you can hit the return button. And I just want to focus on the whole milk, the whole cow's milk right now, and the egg. And you can see that there's a corresponding specific IgE levels to what we're talking about, the subject for cow's milk and egg today. You can see that the cutoff levels that were reported in these studies using a meta-analysis for all ages, and you can see the numbers within the brackets indicates there's a 95% confidence interval for a positive predictive value that, hey, if they get out, if they're above those areas, and Elka, you can hit return, and you can see for the milk, it was like 3.5, 3.5, but you can see the range was 0.9 to 10.5 when we looked at milk. So when we see the cutoff values vary depending on the different populations, geographic locations, and the ages and the gender. So I just wanted to share that with you. So just as a reminder, you can return this. We will continue from what we call a top-down approach, meaning that we can use molecular IgE testing. It provides more details. IACI recommends that single allergy testing versus multiple or broad-based testing, which we'll touch on a little bit shortly. We can see some of the benefits of specific IgE when it compares to skin prick testing. Not sure if you know, but skin prick testing does not provide component information. It doesn't give that molecular detail information that you need. And of course, when we talk about the basophil activation test, it's not really mainstream, but there's a lot of research going right now. It's usually done in research and academic centers. It's not widely available. And of course, the oral food challenge is the gold standard, as you know. So we're talking about that top-down approach. I just wanted to share with this group in 2022, Iaki published something called the MUGA. So return. That's the Molecular Allergy Users Guide 2.0. It was published in 2022. And if you hit next slide, on that MUGA, you'll see on page 38, if you return, there's what we call the diagnostic workup. It's really focusing on what we call the singleplex to really target and be very selective on the foods that we will order versus a broad-based bottom-up approach. And so we want to be very selective when we do this. And so they really point out you can use the very targeted approach. Usually going to be symptom-based, specifically looking at what did those patients present with, what foods they were ingested or come in contact with, and let's investigate that versus casting a wide net and then working backwards, because that can do more harm than good. Because we know that certain tests are very sensitive, and so we don't want to take and eliminate patients off of certain foods that have nutritional value. So let's jump into what is component resolved diagnostics. As you know, this innovation, next slide, you can really change the practice and really improve patient care. I love component resolved diagnostic because it really contributes to the solution of the diagnostic dilemma, and it really helps us really stratify or risk stratify what proteins, after we do a deep dive to figure out what proteins put the patient at high risk and what patient proteins put them at a low risk, or may explain what we call cross-reactivity, because the immune system looks at the biological and the structure as it might be, but these cross-reactive proteins really doesn't have any consequential or non-clinical significance. So it really helps tell the story. So next slide. I wanted to just touch on this. It's just a simple reminder. We're all familiar with ordering a routine cholesterol test, right? And much like cholesterol, you probably wouldn't manage or make a decision just off the total cholesterol. You would like the rest of the panel, right? You would like the HDL, the LDL, the triglycerides, and even some of the other fractionated like ApoB to kind of help guide your management. Very similar to allergy. You got the whole allergen, but guess what? What if you had more information to tell the rest of the story? It helps you complete the diagnostic picture. So let's jump into how do we incorporate component resolved diagnostic testing into modern medicine? Let's look at the next. From a Western standpoint and a European standpoint, there's what we call this top down, right? And so we always start with the clinical history, right? After you get the clinical history, depending on that, we get that pre-test probability. We do some whole allergen testing. After that, traditionally, we would do what we call the oral food challenge, right? We're trying to guess, and then we go ahead and make the patient management. But the good news is, in today's or modern medicine, or what we call precision medicine, now we have something to fill the gap, and that's with the allergen component testing. And so just wanted to share with you, currently, here are the 31 component resolved diagnostics that are available in India. And you can see there's a variety that includes some foods, some grasses, some trees, some weeds, some molds, some dust mites. And so this complementing of components can change the way you practice in India to get the best outcome for your patients. And so today, we'll just focus on the egg and milk. Both of these, next slide, you have 3 for both. Once you get the whole allergen, it is elevated over the 0.1, it will auto reflex to those 3 components for both. I will share with you that in the US and Europe, most eggs come from the chickens. But what I've learned is that in certain parts of Asia and also Europe, there are other use of eggs that could be from coming from quail, can come from turkey, duck, or goose. And even with the cow's milk, that it was interesting to me that 80% of the total global milk production comes from cows. But we know that there's other animals that are used for milk production too, like buffalo, goat, and sheep, and camel. And so, but there is both some cross reactivity with the mammalian milk. So once again, I just wanted to touch on before we get into the difference between singleplex and multiplex. I just want to share with this next slide that this is just a simple reminder that the IACI is stressing to us that we should use that top-down approach. IACI is recommending also the singleplex method versus the broad-based multiplex approach. So next slide. So let's look at, when does one make a decision to use or consider using multiplex? The IACI guidelines for diagnosing an IgE-mediated food allergy, Santos and colleagues, and you'll see on the next slide, that they recommend never use multiplex testing for screening or as the first line testing. Okay, there's a time and a place for multiplexing, but not for the screening and first line testing. And why not use this bottom-up approach? Multiplex testing can provide a lot of great information on sensitization levels, right? And which means that it can be non-clinical relevant, meaning that patients, it shows them and displays them sensitization, but they may not really know how to understand and interpret these tests. And so it's incumbent upon us to use this technology and to use the best approach to really go after those suspected food or foods only versus using a wide net approach, a bottom-up approach. So next slide. Why not practice screening in bottom-up approach? Usage is not in line with the provided guidance and the evidence. It can have a negative impact on the patients as well as the healthcare system. The Society of Pediatric Allergology and Immunologists, their stance is the use of multiplex is harmful when there's a lack of knowledge of molecular allergology interpretation. So interpretation of this is so important, especially if the patient receives a complex report and trying to figure out, what does all this mean? Does this clinically impact me? And so we have to put it all together. This is where we help them understand that sensitization doesn't always mean allergy. So the next slide is going to show, when is the appropriate time to use multiplex? There is a time and a place for that. And the time is when the patient or parent presents that is not a good historian, or the history is not clear, or the case is complex and there's a potential of polysensitization, or you got this idiopathic anaphylaxis and you're trying to uncover the etiology, then that may be a time to use the multiplex. So next slide. Let's jump into the two food allergens that we're going to talk about today. We're going to talk about egg and milk. It's all about protein stability. The question is, what proteins are stable and which proteins denature when exposed to a level of high heat? When I say high heat, when the heat is over 350 degrees for at least 20 to 30 minutes, or it comes in contact with the gastric enzymes. And the question is, can this patient tolerate baked products? And we're going to talk about risk stratification in a second. So it's all about protein stability. So next slide, we see here, you have two, the milk and the egg. Both have three components. So the question is, some proteins don't change their structure when exposed to high heat. You see milk has three, and you can see here casein, you can see casein and ovomucoid, those are protein stable. Those do not break down to high heat or gastric enzymes. And you can see here that it was stated that this is the good news. Those children that once had the cow's milk allergy or the egg milk allergy, 75% for milk and 70% for children, when they went on to do the oral food challenge, they was able to pass because they had those components that did denature, that did break down to the baked food challenge. So those patients were able to go on to enjoy and live a life without avoiding certain things, and they didn't have to carry EpiPen, and they just did close follow up. So that was good news. So let's get into this case study I wanted to share with the group. And so here is a 2-year-old boy coming in complaining, falling up because uh, he has suffered from eczema since he was a infant, and so he's checking in at his 2-year follow up, and eczema is still noted, and now he's beginning to experience a little bit more intermittent GI upset complaints with his parents and his grandparents. Unfortunately, the parents and the grandparents are not very good historians, so they really can't determine what is triggering his symptoms, what is making his symptoms worse and not getting better. So in this case, the clinician orders the food panel, right? Because there's this ambiguity, this idiopathic. The patients, the caregivers are not good historians, so they go on to order the test. Next slide, the panel in this case, and we see that the whole egg white came back to 3.7 kilounits of allergen per liter. And the good news is we were able to get the reflex since it was over that 0.1. And we see that the ovomucoid is less than 0.1. And we see that that the ovalbumin and the conalbumin were slightly elevated. And next slide, and we'll see, what does all this mean? How do we put all this together? So when we look a little closer and we see that we have the egg white and we have certain components that are elevated, but the good news is it's not the one that's heat stable, the ovomucoid. So when we look at this, when we send this patient, if this patient went on to do an oral food challenge, the probability of them passing is very high. They could probably tolerate a baked egg product because he has those two proteins, the ovalbumin and the conalbumin, that will break down. So next slide. And as a reminder, just trying to draw the picture, this is Hugh Sampson, right? This is for his patients, his population, and you have to determine, and Iyaki has something very similar, but you will have to look at your area population. And we can see here, if you hit return, you remember that the egg, the whole egg was what? When we looked at it, it was 3 point, I think it was 3 point, if you hit return, we'll see here, it was 3.7. And so if you look at the egg, you can see here in Hugh Sampson, it was 3.7. It was right in that gray zone. So it leaves us in this diagnostic dilemma. Would this patient pass an oral food challenge? So return. .7, so that gray zone. But coming back, return again. So coming back here, on the next slide, we will see now that we have some data, so we can see that yes, the egg is elevated. And the good news is we can see that the ovalbumin and the conalbumin, they will break down. There's a strong likelihood that this patient will go on to pass an oral food challenge with a level of confidence. It makes the parents happy, makes the patient a little, his anxiety goes down, and this patient will probably be able to go on and grow out and have a tolerance for egg eventually. It may not have a lifelong sentence with egg allergy diagnosis. So next slide. And so on follow-up, we did recommend that the patient goes on to get a food or a challenge, right? The good news is This patient was able to pass the oral food challenge with the baked egg products, but we caution and remind them still avoid any raw or uncooked eggs products. Also, it was recommended that this patient, because once again he's young, we want to watch him and monitor him. Some allergists may recommend to repeat the egg panel again in a year or two, just to make sure that, let's see if this patient is developing a tolerance to egg. So next slide, let's get into this next case, and we'll come into the end after this next case. Let's look at this case. This is a 7-month-old female. She's transitioning from breast milk to supplement with formula. But the parents has noticed over the past month, this patient is starting to develop more gastrointestinal distress. The patient is now having some vomiting and developing some hives. And so the patient is brought into the clinician or the physician, and now based upon the history, we can say, hey, is it the milk? Is it some wheat based products based upon the history that we're getting from the parents? And so we go on specifically using the singleplex method to look at the wheat and the milk with reflex. So let's look at this. The question was brought to the table from the parents is because in 5 months, this patient will be celebrating their birthday, right? The 1-year birthday. So if he had returned, the parents are concerned about, will my child be able to enjoy the cake? Will they be able to enjoy the ice cream like their cousins and their other family members, right? So we want to be able to answer that question. So next slide. So we do some testing, and we can see here that we have, the good news is not wheat, but we do see that the milk is elevated 2.0. And also some of the other components we see are elevated as well. We see the alpha lactalbumin is 2.0. We see the beta lactoglobulin is less than that, so that's not elevated. But this caused me to pause. We have that BOSD8 or casein is elevated. So let's look at that, and let's determine, where does this patient fall into when we look at the decision cut points. Will this patient pass the food allergy test? And so you remember milk was what, 2.3, right? And so once again, this is Hugh Sampson. It leaves us in that gray zone. Will this patient pass an oral food challenge? Or if I subject this patient to an oral food challenge, will they fail it and become anaphylaxis? Am I doing this patient justice? So when we look at this, go to the next slide, we see now that we have the good news with reflex testing, we have some additional information. We see that the alpha lactalbumin is 2.0. That's one of those proteins that break down. But unfortunately, she has the casein. That casein is 8.0. And as you remember, on the next slide, you'll see casein puts the patient at risk. That's the protein that does not denature. It doesn't break down to high heated elements, and it doesn't break down in the gastric enzymes. So this patient, if we go to the next slide, we'll still send him to the allergist, right? We'll still watch him and monitor him, but he doesn't or she doesn't need to be oral food challenged because of the history. We got that pre-test probability, and now we got post-test probability with a high level of accuracy and confidence that if I were to subject this patient to a baked oral food challenge to milk, this patient will fail with a level of high certainty. Okay. And so what we do with this patient, because of the history, we want them to strictly avoid it. All types of milk avoided, right? Pasteurized, raw, just avoid it, unfortunately. All right. And so let's go to the next slide. So I just want to wrap things up and share with you the patient journey, something to consider either from the primary care level or from the specialist level you'll see here. But they both all began with that pre-test probability, looking and using that top-down approach. It all begins with that, having that high clinical suspicion, starts with that history. Then we take it to the next level, right? We can do some in vitro testing. using singleplex, looking for those specific allergens, right? And be very targeted in what we're trying to do so we can investigate that and then determine, is this, once we get the results back, using that post-test probability. And then trying to determine with, if we need, if it does, that whole allergen uh, comes back elevated reflexes, and then we can use multiplex for those concerns, those question mark areas where idiopathic, that when the patients and the parent doesn't have a good history. The society supports the IACI and other guidelines from around the world that shows a strong level of evidence that um, we should do a singleplex count approach. You can go on to the summary here. Oh yeah. So these are the three components we talked about. I'm sorry. The three the components. There's three for milk and three for egg. So I just wanted to remind you of that. And then now coming to the summary slide, and we'll close with this, is that just want to share with you that the prevalence of food allergy is definitely continued to rise in India and across the world. And so the society really supports using the best practice, the strong evidence and the guidelines from Europe and even Western society to look at those approaches, because we know that certain patients really overreport, but we really need to be able to rule in and rule out to help these patients manage their diagnosis. And so using immunocap is recognized and cited as the gold standard across the globe. And so we want to be able to use that. And then we talked about the component resolved diagnostics today, as far as looking at what is the value. They give us more information, more available information, so we can make a better decision making in managing our patients. And also, just to close out, we really want to minimize and avoid using screening and multiplex as a first line. We want to use the singleplex method, because that really going to tailor and be using specific precision medicine to get the best outcome. So I just want to thank you for your time, and we'll stop right there and open it up for questions.
Thank you so much, Dr. Derrick. There are a few questions I can see in chat. So, how reliable are the values if done while on omalizumab treatment?
Okay, let's get in here. And you said, how reliable are the values done by?
If done while on omalizumab
Yes.
treatment.
So the biologics, yeah, yeah. So there have been some research, and I think it's ongoing, that shows that there may even be some changes, some minor changes, but it still would not affect the overall management of the patients. If the patient is on biologics, that means they're at a level of severity to help manage these patients, and so you will see some changes over time on the biologics.
Okay. So next question is, can we do immunocap cardiotop infant or adult as a screening test before doing skin prick test?
Yeah, I would share with the group that, as the guidelines are sharing with us, that we should avoid doing screening tests, right? If there's no clinical symptomatology, there's you have to ask yourself, why am I doing a screening test, right? It should be based upon symptoms, and that's that top-down approach, so we can really figure out what is dry. Is it sensitization? And then, if it is sensitization, is it the culprit? Is it triggering uh, the symptoms for IgE mediated? Because you can have a quantitative elevation, and also you can have, as I shared with you, you can have a positive skin test. But the question is, are they clinical symptomatic? And to your other point, can you use immunocap in infants and adults? Absolutely, especially for food. It's a little different than respiratory, but food, as we saw in the scenarios, and plus when you do the panel discussion, we'll see that you can use this to help manage those patients that do present with a questionable, a high suspicion of clinical allergy.
So he has asked the same question for all allergic symptom patients, first doing cardiac top, and if it is positive, then I'm doing skin prick test. So is it correct?
Yeah, I would say if I can go back, let me go back to the other question. Could you use them? I would tell you that in the U.S., some allergists are doing both. We have a different reimbursement than some countries, and so when skin prick tests are considered procedures, and I like doing procedures, and so we get reimbursed, or patients have to pay more for that. And some do both tests. But going back to is if it's positive, and they go back and forth. Believe it or not, in primary care, we as far as providers, we can't not do skin prick testing. We're not set up for that. A lot of us don't have the crash carts and ready to do the standardized. You got to be trained so you can get the same technique, the one that's doing the skin prick testing. And so that really takes the blood testing really makes it standardized. It takes the guesswork out and is reproducible. Because I know certain people that do skin prick testing may not do it all the same way, the same technique. And so I don't know if that helped answer your question or not. I'm sorry.
Okay. Next question is in a patient with suspected hemosiderosis from cow's milk, would it be utilizing the same milk allergy test?
That's a good question. I will have to do a little bit more research on that and get back with you um, uh, to make sure that I answer that correctly for that hemosiderosis. Yeah.
Okay. So I think these are the only questions right now, Dr. Derek. And
Mm-hmm.
I really thank you so much for the wonderful session. So I would now we would open the forum for the panel discussion. So yeah, there is another question coming up. What is your take on adults with respiratory allergies, top down or bottom up, multiplex or singleplex?
Yeah. So my take on adults with very respiratory is a little bit different than the food things in the environment, outdoors and indoors, that we can miss. And so I would there are times that from an occupational standpoint, I may do very targeted, very specific air allergens based upon the occupational exposure. But for the everyday population, there are things that I definitely want to be able to investigate and also still use a top-down approach with using the inhalant allergens, because then I can begin to ask those questions. When you're exposed to X allergen, do you have symptoms? And I can work that way back. So there is that time and place to use singleplex versus multiplex and vice versa. Absolutely.
Okay. Another important question is if egg yolk can be tried in children without anaphylaxis.
Yeah. That's a good question. I would tell you that it may be hard to separate the egg white from the egg yolk because there's going to be some cross contamination. Um, and so, can you have egg yolk in children without anaphylaxis? If I'm learning never to say never, but because of the cross contamination of the majority of the proteins are in the egg white for the most part, not in the egg yolk. But once again, it's just difficult to separate it entirely and completely. And so there's always that possibility to have that as well.
Is it that except mare milk, rest all have cross reactivity?
Except mirror milk breast. Uh, I'm not sure the mirror milk. Mirror milk. What's that? Is that
Uh,
I'm not sure.
with
If they can expound on it.
no worries.
Horse milk
Could you
basically
elaborate?
was no
Horse
horse
milk.
milk. Horse milk.
Horse milk?
Yes.
Ah, yeah. I think it was, certain countries, certain eras, they're using camel, goat, buffalo milk, right? That there's still that potential chance of those patients that there may be some cross reactivity or those proteins that may be in those mammalian products or the mammalian source as well. So there's a potential for that to happen.
Okay. Okay, Dr. Derek. Now there are no more questions. So thank you so much for this wonderful session. Now I would call upon Dr. Ellen Pereira to start with the panel discussion. And I hope you will be there for panel discussion too, if your time permits. So please be there for panel discussion.
Okay.
So
So
Dr. Ellen, you
yes.
start.
Good evening. Yeah, is my screen visible?
Yes, yes, yes.
Okay. Thank you, Dr. Derrick. That was a wonderful session. You gave us a lot of insights, especially on CRD, how to understand. I think the most important part was where you really broke down the difference between a heat stable and a heat liable protein. That will surely help us make good clinical decisions coming forward. So I am thankful to Thermo Fisher and IIP for giving me this opportunity, and at the same time, I'd like to invite my panelists, Dr. Mitesh Kakkad, who's a senior consultant pediatrician and an allergist, who has done his diploma in pediatric allergy and asthma and an advanced course on diagnosis of allergies and immunotherapy. He's also done his diploma in pediatric sleep medicine. We have Dr. Mangai Sinha with us, who's done a DNB in pediatrics, an FACI, as well as a certificate course in allergy and immunology from VN Allergy Center. She's done her immunology as well as her immune tolerance from Harvard Medical College, Medical School, sorry. And of course, Dr. Shraddha Soni, who's a consultant pulmonologist practicing at Mathura, done a FACI as well as a fellowship in sleep medicine, authored chapter in IIP books, and is the founder at SWAS Chest Clinic and Allergy Sleep Center at Mathura. Good evening to you all, and I'm happy to have you all here with us tonight.
Evening.
Good evening.
Good evening, everyone.
So, without any further ado, I think we will jump into the cases where we will be talking about the CRD diagnosis, how it has helped the patients, and what decisions the practicing physicians could take based on those reports. So, when we look at the first case, we look at a patient who was Jill, a 5-year-old girl who came with a history of egg allergy. So basically, she was a known case of egg allergies, visited her primary healthcare provider after she had recently eaten a cake at a birthday party. So her mother reported that even though she has consumed eggs in the form of a cake, there was no reactions. So she wanted to know, has Jill grown out of her egg allergy or no? So her provider, on taking a proper full clinical history and an examination, decided that it would be optimum to undergo a test with egg whites and reflex seeing for the components. She had no family history, and as per her past history, there was mild eczema as an infant after eating eggs. There was no history of anaphylaxis, following which the patient was on egg devoid diet. So basically, she had no eggs in any form. So the immunocap, which was done, basically showed the whole allergen, which was the egg white, as a 6.4, which was positive, over mucoid negative, and over albumin to be positive. That was a component test to show a result of 5.42. So based on this report, uh, the patient was in parents were counseled that being overmucoid, she could eat extensively baked eggs, and following which the patient may consider undergoing open challenge or open food challenge. So for further course of action, they went to an allergist specialist for an oral food challenge, which she passed without any symptoms. As we had clearly seen earlier, she was allergic to albumin, which is heat labile. So she was reintroduced to extensively baked eggs in cakes or in biscuits, and overall, she is having extensively cooked eggs now in part of her daily diet. We'll have a look at the second case. So in second case, we see a patient, Alice, who's 7 years old and experienced a lot of GI issues in the form of GI disturbance, vomiting, and even urticaria after having products containing milk. So taking this history, she went forward to her medical provider, and after a good history, they decided to do a test with milk with reflex to components. Having no positive family history, and having the clinical history of GI disturbance, they went ahead with the milk testing with reflex. So the whole milk was positive for 12. BOS-D, that is alpha-lactalbumin, came positive at 1.22, and BOS-D8, which is casein, was positive at 7.53. While BOS-D5, which is beta-lactglobulin, was negative. So keeping this in mind, the allergist, the clinician said that with these values, especially sorry, with these values, especially with the casein, the patient, that is Alice, was unlikely to become tolerant to milk over time. And therefore, she was advised to avoid all milk-based foods in whichever form it was. So as long as she kept milk out of her diet, patient did well, and she was following up, and the patient had no issues. So similarly, this is another patient where we see with a known case of milk allergy. And as the patient was already 5 years old, who was parents wanted to know whether she could tolerate baked milk, as most of them can tolerate heated milk. After around 75% of them do tolerate cooked milk. So her tests for milk was positive at 2.1. Alpha-lactalbumin was positive 1.2. Her beta-lactglobulin as well as casein were both negative. So the parents were counseled that as she's sensitized to lactalbumin, the reactions may be reduced when truly heated, when the milk is well cooked in the form of cakes or cookies or muffins, and was then referred to a allergist who did her oral milk challenge, and the patient passed that without any symptoms. They also recommended that we should retest the patient after a couple of years to see whether the values have decreased, and as we know, most patients outgrow their allergen, the milk allergy. Now coming down to the last case. So this patient was around 5 years old, who came with the history of cold since 2 days, breathlessness since 2 days, which was gradually increasing in spite of taking nebulizations at home. So this patient came and was admitted in the PICU with severe breathlessness, and a patient had some amount of desaturations. There was history that patient has severe urticaria upon consuming milk, as well as localized lesions if the child touches milk, or someone who has handled milk products comes and touches the child. So in terms of allergy management, the patient was currently avoiding all milk and milk products. The parents were pretty strict and pretty confident that they had not given this child any kind of milk products or exposed him to any milk prior to the onset of the sudden breathlessness which was there. This child was confirmed or rather diagnosed as having CMPA at 2 years of age. Unfortunately, we did not have the complete detailed records of this patient in terms of allergy testing, but somewhere in his medical records, doctor has mentioned that a milk test was done, which was considered positive, following which the patients were avoiding milk in any form. So currently, child avoids milk in any form, and he has a history of cough intermittently, for which he takes nebulizations SOS if required. Since we had a positive, a medical record mentioning positive allergy to milk, and patients were very confident, the parents were very confident that they haven't exposed the child to anything that can trigger such sudden onset breathlessness, and for him to get so bad, we decided that we would do a multiplex study because we already had a milk positive. We thought we could, in the same test, we could see what are the various components which are positive. So the allergy testing, which was a comprehensive CRD, was done, and it gave us multiple sensitizations. It showed us the child is multi-sensitized to many proteins, where cow's milk BOS-D was 10, which was a very high number, out of which albumin was 18, lat globulin was 27, and casein was 9. He also showed cross positivity or cross sensitization to other milk, that is goat, sheep, camel, as well as cattle meat. But what was also significant was to see that child was also sensitized very strongly to dust mites, where we seen a DF1, DF2, P1, as well as P2 strong positive. His total IgE was about 2,500, but other common foods were negative, such as egg whites, peanuts, soy, lentil, all those were negative, as well as a lot of pollen, yeast, fungus were negative. Later on discharge, patient was reassessed for asthma. FOT was carried out, which showed good reversibility. So the patient was then managed on regular MDIs, as well as strict avoidance of all milk and milk products, with the aim that the that he would be re-evaluated for milk allergens and then counseled accordingly. So right now he's well controlled with MDIs. He has his plan is to go ahead, and we are planning to repeat his testing to check whether he has whether his allergen levels, his serum Ig levels have decreased, and that is where we plan to take it further on. So we will open this. So these are some certain example of cases. So where we will open the forum now for questions to our audience, where we can discuss a few of these cases or few of these clinical aspects in detail.
I can add something in last
Yes,
case.
yes, yes, sure, sir. Yes.
So as Dr. Derrick said, in this case also, the single plex would have been better option, because as there is a clear-cut history of milk anaphylaxis, severe case of milk anaphylaxis, right? So we could have done BOS D8, BOS D4, BOS D5, number one. As patient was
Yes.
admitted for asthma, and after taking detailed history, and if there is no allergic rhinitis, then we can go for after having perineal symptoms history, we can go for house dust mite singleplex also. So multiplex here also shows so many sensitizations which are not relevant clinically. So this is also in even patient of milk allergy or food allergy with anaphylaxis with comorbidity asthma, we can go for singleplex for house dust mite and for this cow milk allergen.
Yes, sir. Unfortunately, that was before we had Thermo Fisher with us. So since
Yeah,
now we have the
it
options
was
of a
yeah,
single
we know.
plex, I think we can. It makes the clinical acumen
We
more
can
useful.
revise our now after this lecture, and Thermo Fisher have
We can,
come with this single plex.
yes. So I think that helps us a lot because the unwanted or clinically insignificant sensitizations get
Sensitivities.
ruled out. So there's less confusion.
in the last case, apart from the milk allergy, since the aeroallergen, the dust mite is also positive, that could also be one of the reasons for the child having breathlessness and asthma. So it could be case of polysensitization rather than just focusing on milk allergy. I would also look into that part of it.
It could very well be that if, the child was polysensitized, and we really did not have the reports which was done earlier when he was 2 years old. So at that point, maybe based on clinical symptoms, only milk might have been done, and the parents might have also were treating or rather having proper milk avoidance based on that.
and and after correction of asthma, and if everyone becomes more than 70, we can think of, or we can counsel for dust mite immunotherapy also.
So that is basically what the path on which they are on. So he is on MDI, and so basically dust mite immunotherapy is one of the things. Now milk, whether we should desensitize or give OIT is the question which we will have to face when the time comes.
I think what I
So
could just wanted to add, I think what I could really derive from Dr. Derrick's extensive talk is that this component resolved diagnostics, it actually helps us, because if you see the cases that he also explained, and even right now the cases that you presented, these are 5-year-olds and 7-year-olds who have been completely deprived of either the egg or the milk because of some reaction. Whereas in one case, it is the minor allergen, that is the heat labile allergen. So if it was done at that time, then the child could have actually been given baked products or the same allergen in a modified form. Completely avoiding it leads to nutritional deficiencies, and that is one important angle. Also, the fear that what if my child gets exposed to it accidentally, that fear in parents is very much, because milk and egg are very common products which are there in all food, and not only that, they are very common contaminants also. Like wherever you go, even in a restaurant or something, if the same food is cooked in that same, the child with such severe allergies may end up having a reaction even to food which they may avoid, but likely may have some contamination. Just that here is where the role of CRD comes. That is what I could.
In one of the cases, casein was positive, bosdiate was strongly positive,
yes.
right? So here there are some misconception in parents also, because they, if you say that milk is positive, they will avoid only milk. They will give goat milk, sheep milk, buffalo milk, and all milk products, buttermilk, cheese, butter, ghee, everything. And here is the role of singleplex bosdiate. If casein is positive, so you have to counsel at parents level, at home level, avoid cross contamination at restaurant level, school level, avoid gathering. This you have to be very strict, and avoidance should be very vigilant for casein positive milk allergy, right? So they can end up into the anaphylaxis, and you have to give anaphylaxis action plan at all level, parents level, school level, everywhere. And here our EpiPen is not available, right?
But
So
we do have.
Indigenous, yeah, we can make
Yes.
indigenous.
In India, I think a lot of patients, a lot of doctors also think all allergies are major, or rather most common cause of allergies are food. So we do see a lot of patients, whether they have eczema or rhinitis or asthma. First thing that is the first thing that a patient stops is a long list of food, and they are psychologically imbibed that if you eat something, you're going to fall sick. So the root cause of all your allergies or you falling sick often is food, I think, and that causes a lot of psychological trauma as well as nutritional deficiencies in our patients. We've got a couple of questions. So first one says that a 1.5-year-old male came to my OPD with complaints of abdominal pain and loose stools after drinking milk. There's no history of any skin symptoms, and how do we approach? So we really do not have for how long this complaints are there, as for what was the onset of it. So I think it's open to
Um,
the
a more
panelists.
detailed history of, like Sir said in his lecture, the complete diagnostic, like it starts from a detailed history, all the questions of what was the timeline, like when the child consumed and when did the symptoms start and how severe was it. So all the detailed history of in what form did the child have, when did the child have the complaints, the entire questions has to be answered and a detailed history taken, so that we have some more clarity into the picture. So here, the first question that I would really like to ask is whether it was just pain in abdomen or loose stools, which is again limited to the GI tract, or was there any other symptoms? What was the timeline of it? A detailed history, which would give me clarity whether I would need further testing or whether I would just think that it is some lactose intolerance or some other picture of infection or something like that. So how to approach first a history, and then we see from the history what the questions come, and then we can go ahead.
I agree. I think we need a detailed and complete history. There's a lot of information which we do require before we come to a diagnosis. The next question, which is there is, how long should the suspected food allergen be avoided? Can we consider desensitization after a particular period? And would adults outgrow the food allergy?
So here it depends on the what type of food allergic you are to, food allergen, type of food allergen. And if you see the milk and egg, usually the child will outgrow after 5 to 6 years of age, almost 70 to 80%. But if you see the shellfish, fish, and tree nuts, they are difficult to outgrow. So then here also there will be a role of this single plex food allergen testing. If you are heat stable, the persistence of the allergy, you are positive to heat stable protein, then persistence of allergy and severity of anaphylaxis will be there for a longer time. So it depends on the individual allergen, food allergen. You have, if each stable proteins are positive, strict avoidance is must to avoid anaphylaxis. That is firm. And if you are in doubt with the history or some SPT or IgE, you can go for oral food challenge. So the psychological stress will be less for the parents.
Then there's a question as to what are the causes of elderly onset food allergy? Dr. Shraddha, you're not audible. Yes.
Sorry. I think so. The cross reaction with the dust mite allergy or a pollen allergy in the adult onset, maybe the pollen allergy that causes abs. And it is dust mite allergy is also one of the causes in the adult. Mostly the milk and this egg allergy resolves at the study is right at the 5 years of age. That not persist.
But the data suggested that the egg yolk allergy usually we see in adult, and the persistent, the whether child is out is having persistent of allergy through adolescence or adult, or there is a new onset of adult allergy of food allergy onset. There are
Mostly, so
two
there is a
different.
pain in mostly, so there is a pain in abdomen. Mostly, they complain the adult sips, not a severe anaphylaxis I have seen. Only that is their discomfort mostly. I think so. Sir will reply. Derek sir will reply.
Dr. Derrick, you're muted. I am. Yes.
Yeah, I was just going to say I agree with the other panelists, especially when it comes to the dust mites. I can speak from a U.S. perspective where I'm at in Texas, San Antonio, Texas, and so we have a lot of environmental indoor with the house dust mite and the cockroaches. And so now what I'm seeing to the question was elderly or adult or geriatrics. I'm seeing more women that are predisposed to shellfish
Yes.
that have that those predisposed aero allergens, and now they're developing sensitization and anaphylaxis to shellfish. So the immune system is complex, right? And so everybody's different. Everybody's threshold is different. and different things will cause and trigger other things in the immune system to respond a certain way. And so it all goes back to the history, right? Asking those key questions. And a lot of us, the truth be told, we don't want to ask those questions because it takes time. But I do believe if we take the time up front, we can save the patients a lot of undue emotional stress in their caregivers and also us and the health system as well. And so that's just my take on it.
There are two food allergies also we see in adult. There are oral pollen syndrome, and food dependent exercise induced anaphylaxis.
Yes,
These two
yes.
entities adults can also have manifest in their adulthood.
Totally agree.
Mostly due to cross reaction of tropomycin, mostly we have seen that is what sir have said.
So a lot of cross reactions as well as
Yeah.
neosensitizations do occur in adults. So it is against the belief that all allergies start in childhood. That is something which we have to keep in mind, that adults can develop neosensitizations and neoallergies.
Neosensitizations and the allergy threshold. The moment they will hit the allergy
Yes,
threshold, they'll start showing
they
reactions.
change
Till
reactions.
they don't show, they will be symptom free.
So quite often we get patients saying that, I have been eating this or exposed to this since childhood or since many years. So they think
Never get that.
everything starts from birth. So there's another question. Would blood Ag levels differ in sensitization versus allergy? I guess it would mean IgE, maybe not Ag.
What is the question?
See, 41 years
Would
seeing
would blood Ag levels differ in sensitization versus allergy?
So
By
sensitization is production of IgE, and allergy is your symptomatology. So when you have sensitization, doesn't mean allergy.
And again, we cannot say that it is allergy just based on the IgE levels, because IgE levels may be extremely high, but the child may not have allergy. Especially for us Indians, there are studies where certain countries like Indians in Southeast Asia, we have shown sensitization to most of the food allergies and aeroallergens to the tune of 25 to 26%. The sensitization is there, but these were completely the normal children without any symptoms of allergy. This is according to the Europrevail study, which was an extensive study done in India itself. That is when it came to conclusions that uh, there are few countries where the population, not one or two, the entire population has produces a lot of serum IgE. So only serum IgE cannot, or high serum IgE levels cannot be labeled as having allergy.
I think this
Yes.
is where we have to realize we are not treating the report, but we are treating the patient. And just an IgE or a SPT which is positive without a relevant or history which has got a temporal significance cannot be just labeled as allergy. So just don't go by the number.
Many
Talk to
times I
your
have
patient.
seen allergic rhinitis patients are having a local rhinitis. They are not. There's a totally allergy symptoms are there typically, but CRD definitely negative. I've seen also the same
Negative.
cases like this. But definitely, then I say go for a local treatment and just precaution with the dust and the cold and other aggravating factors, and they are doing well in this case.
Completely agreed with you, ma'am. So we have to really look at the patient as a whole and just not the paper.
Yeah.
So you were about to say something, Dr. Derrick. I
No, sir. I was just excited. I'm so glad you said that, and I think that trips up a lot of clinicians and physicians. They treat the numbers versus the patient. Sometimes we even don't touch the patient, right? And so we got to get back to the basics. Is everybody? I love this panel
Yeah.
is saying
So
that we
there
got
is
to.
definitely there's a polyp I have seen in the small childs and adenoid is seen. That is a worst. That is a thing. That is we treat a locally with the nasal wash reducing. That is a help a lot to the patients.
So there's another clinical question. A 7-year male with symptoms of allergic rhinitis and intermittent asthma was found to have egg yolk GAL-D as 0.35, total IgE 42. and rest CRD multiplex as negative. So what would be your further plan?
It's just a sensitization. There are no symptoms of egg allergy, no hives, no urticaria, no anaphylaxis, no GI symptoms, just respiratory symptoms. So just avoid. Why you want to do egg allergy test in this patient? Just do HDM or aeroallergen test. If you are suspecting allergic rhinitis with asthma, aeroallergen, indoor or perennial or outdoor allergen, you can go for that. And so, as our fourth case, polysensitized to so many things, but patient had asthma and only allergic symptoms to milk. So, why to go for egg yolk testing in this patient? So,
I think we have to
that is
remember the
top to bottom approach, as Dr. Derrick said.
Derrick. We have to think of local allergic rhinitis, and asthma may have many other causes apart from just an allergy which is there.
And in all cases, directly you should not jump to the CRD. Here I can see the rest multiplex CRD is negative. So we have to go stepwise. CRD definitely is helpful, but that is not the whole and soul allergy test. It should be as a complementary to the other test, but it should not be that that should be the first test that should be done in any child suspected of allergy.
So basically, what we're also trying to say is that CRD does not replace an SPT or an IgE. It is not a substitution, but something that complements them.
Yeah, true. It will add on. It will give us more idea, but that too in all patients, you don't even need to come to that level. If you have a detailed history, if you have done good SPT or the serum specific IgE, then only to rule out whether the child will ever outgrow or how severe it is and all, then we do the CRD. The CRD will help only then and not as a first line.
But in this case, we as the Indian, we don't have a pollens of the India. Okay, the CRD there's a mostly like there's a very few pollens are there. In that cases, may further we can check for the SPT with the hair areas, geographical areas pollens. In this case,
it'll be more of aeroallergen testing that needs to be done, and rather than think about egg yolk. The only thing that I would say, egg yolk has this alpha levitin allergen. That is, so that generally people are not allergic to egg yolk, but in very few cases there is this bird egg syndrome where you can have cross reactivity between this alpha levitin to other poultry eggs. So that is the only thing, if at all there is some connection to it coming positive. That's it. But that has no significance in a case of allergic rhinitis or asthma as the symptoms.
When a 41-year female gets severe pricking sensations in her throat and below the tongue after consuming cold coffee, almond milk, chocolates, cake. So will a CRD help here? And is this an OAS?
This is okay. Anybody can take. This is mostly because of the content of the synthetic colors and additives in the chocolates, and some of the food they have high histamine level, so that can cause local irritation and throat itching and this type of symptoms. This is not a true allergy. You don't need any testing. Even SPT or will not help for this.
Oral allergy syndrome is generally seen when we consume fresh fruits and vegetables. That is a tingling sensation or mild swelling in the oral cavity. That is if you have cross reactivity of that particular allergen with any of the pollens. So in case of grass pollens, if you're having raw tomato, then you can have, or if you are allergic to birch pollen, then having apple may cause such reactions. But I don't think a coffee, just like I think like Dr. Mitesh rightly said, it could be any of the additives or substances in the food that she's mentioning would be causing the symptoms.
I think we have to understand most of these foods also mentioned are not something by themselves. It's a combination. Like when we look at chocolates, it is just not milk. We're looking at cocoa, we're looking at chocolate, we're looking at colors, maybe dry fruits. Cold coffee may have other additives. So if a patient shows symptoms to any one of those components when taken individually, we can think of maybe the patient is allergic to that. So again, here a very detailed history and seeing whether the patient is showing any reactions to each of those components, only then it makes sense to say, okay, if no person is allergic to a certain thing. So
If I could say too, remember I showed the two buckets, IgE immune-mediated and non. That one probably, as the panel is saying, it falls into that non-immune-mediated, probably the pharmacological component, because there are certain things like caffeine, some things called theobromide, that's the chocolate, right? That can give that type of sensation, but it's going to be very localized. And so that gives me a level of assurance that, hey, we can treat and manage this at a level that it doesn't need any further investigation unless something else changes in the clinical history, right? So,
so next question, is milk allergies species specific? So I think they mean to ask about the cross sensitization between maybe buffalo milk, cow milk, and camel milk, all those things. So anyone would like to take it?
I think they are cross sensitized buffalo milk. All milks are having cross sensitization. So if you are positive to cow milk, then you have to avoid all these animal milks.
I think almost all
And
mammalian
all
milks
mammals.
show
You cannot
some
take risk.
degree of.
Yeah, you cannot take risk.
Then role of hypoallergic milk and how far are they useful in practice?
So, in children who are diagnosed with milk allergy, extensively hydrolyzed milk is used. It is that only if they have been diagnosed with milk allergy do we recommend that. And if they are not even able to tolerate this extensively hydrolyzed milk formulas, then amino acid formulas. Otherwise, it is only useful and indicated only in that case.
And if here cost is the issue, so you can give soy milk, but for before that you have to do sensitization test for soy milk also, because co-sensitization is almost 10 to 15%. The soy milk is cost effective, but if you are negative for soy milk protein, then you can give soy milk also.
So that's so we certainly shouldn't blindly advise everyone to go in for a extensively hydrolyzed without being clinically sure they are allergic to cow's milk or mammalian milk. Now, next question is, how do we differentiate between lactose intolerance and CMPA, both clinically and via blood tests, in a patient who's 18 months old? And when should we stop milk-based products?
So, here, lactose intolerance is a non-immune mediated or a non-immunological reaction, adverse food reaction, whereas CMPA or cow's milk protein allergy is an immunologically mediated one. In here, clinically, it is that CMPA will have symptoms not only related to the GI, but will have symptoms, the child will have hives, or all other system involvement, which could also include wheezing or even sneezing or sniffles. Whereas in lactose intolerance, it is due to it is mainly restricted to the GI tract. So there will be bloating, there will be some pain in abdomen, and it will only be GI symptoms. Again, CMPA can even a little amount quantity, it is even a little quantity can trigger a CMPA reaction, whereas quantity, only when you cross a certain amount of quantity, that is when you will get this intolerance. You may not get it every time. CMPA, you'll get it every time when you're exposed. Lactose intolerance, sometimes you will tolerate, sometimes you may not tolerate when you ingest huge quantities. So this is the way clinically we do. And in lactose intolerance, you'll not get any of the tests that are positive. So there is, it is completely and purely clinical diagnosis. You don't need to do any tests.
It all comes back down to a very good history and to know what is the trigger, while CMPA is immune mediated and lactose intolerance is non-immune, usually due to a lack of the enzymes. Now, when we look at food intolerance versus food allergy, how do we differentiate it clinically? And how do we explain this to a parent or the caregiver?
Almost same as lactose intolerance and CMP.
Right.
The difference is same almost.
Mostly food allergy reactions happen within the 24 hours, within the 1 hours. We have to differentiate with the history basis. Secondly, they will have a systematic reaction also with the local reaction. Food intolerance mainly the just discomfort, pain in the abdomen or a loose motions like cramps. Mostly they have, or like this simple like GI intolerance.
So I think at least what I have found is a food diary is something which helps us a lot to differentiate between the two and even to identify food allergens. And not just the food diary, but also the onset of symptoms as well as the type of symptoms which are there. So a lot of patients refrain from keeping it, but the food diary, I think, is one of the most important tools which we can have more than a lab test. That diary helps us a lot. Uh, next question is the patient had anaphylaxis after eating shellfish, prawns, and crabs. So, what CRD panel should we send? Should we send a single plex or a multiplex?
Single plex tropomycin, I think that is a better one. Simple.
Pen, if it is confirmed with shrimp and that, we must go for this pan M1 and specific protein for this prawns and shellfish. But history suggesting of anaphylaxis, then I don't think uh, you should go for so many tests.
In a child with eczema, uh, and if the heat labile milk allergy component is positive, what would be your advice on milk avoidance? They haven't mentioned the age. I think that is an important factor. But yes, the rest of the question.
So sometimes there may be aggravation of the eczematic lesions if the child also has food allergy. But again, we really need to know a detailed history of how severe is that. And milk avoidance, yes, even if it's a heat labile component, then it is not complete milk avoidance. The child can take in baked milk products wherein the child will not react. But if what we really need to note is if the eczema aggravates every time, or if there are any other factors that lead to the aggravation of the eczema, and again the mother is thinking that milk is the culprit.
And it is mainly IgE or non-IgE mediated also. So if you are suspecting milk allergy in this exacerbation of eczema, you can give trial of elimination of milk elimination diet for at least 2 weeks and see for the symptoms that whether they are coming down or not.
So with milk allergy, we have another question. In a patient who has milk allergy, complains of breathing difficulty when he smells milk being boiled. What does it mean, and how do we deal with this? How do we?
Uh,
I would say, oh,
yeah,
go ahead.
please sir,
No.
please sir, go ahead.
Okay. I was just going to say that with the milk, once it goes back to the question, right? Was it ingested? What was the contact? Was it ingested, inhaled? Because things can be fertilized. And if it's reproducible upon that exposure, no matter the route, that has bought the diagnosis, right? If it's aerosolized, the patient is coming in contact with it, they get the anaphylactoid response, then that gives me a level of confidence in, that this patient, I need to investigate that, and I would probably do testing, right, to figure things out, either to rule it in or to rule it out, right? I need to help the patient, right? So
I think we have a misconception that food can only be ingested. We forget the fact that it can be inhaled or it can have a dermal contact, or so that is very important.
Though I have never had such a patient, but I clearly remember my sir or our sir, Dr. Nagaraju, telling that he has seen cases where even if the milk is being boiled in the neighbor's house, the child here would break up into hives and lip swelling and have anaphylaxis. So then these are the children where you consider immunotherapy and all, because it is life-threatening, even boiling of milk. So this question just reminded me of sir talking about that case.
Sir even told even after washing that curd bowl and he had that food in that in bowl. I think so that sir also told us that. Right? Yeah, contamination that thing.
So I had a patient from Kuwait who had I think peanuts and milk as well as some other food, and the parents would avoid it completely. But in Kuwait they had central air conditioning. So during the meal preparation time, when before lunch and dinner, that is when the neighbors or people in the building would prepare food. That's the time when she would have a lot of wheezing episodes. And that is when you realize that maybe because of the central air conditioning, there may be some inhaled food particles or other the food allergens which trigger her at that point of time.
Sir, I have a question to Dr. Derrick. Sir,
Yes, sir.
can this CRD will decreases the need of oral food challenge in the future? CRD component result, can we rely so much around 95 to 100% on this to avoid food challenge? Because patients are also very afraid of this food challenge, and we need to take a consent and everything. So can we rely much on CRD to avoid oral food challenge, either for tolerance or for baked products?
I, great question, Doc. I would say that it has its place. It may not totally replace it, but once again, it gives us more information, more pieces to the puzzle to make a good clinical decision. Because I do know several allergists that I call more cavalier. They will challenge anybody, you know, just to make that confirmation. However, there's no 100% test, and so I would just caution us that we use the best information that we have right now, and the literature is saying that it's complementary, right? But I don't think it may replace. But as technology improves, there may come a time,
One
right?
second.
But yes, sir.
Thank you, sir.
You are.
We have another. What is the avoidance measures? What avoidance measures should be advised in a case of pan-allergen NSLTP positivity in patients with respiratory allergy symptoms? So avoidance measures in case of pan-allergen NSLTP positivity with
Yeah.
respiratory symptoms.
Yeah, I would say to this question, and I think we'll probably be in agreement with this. What's the history to that non-specific lipid transfer protein, right? Because we know that's increasing too, right? But what is driving is because that the LTP, it can go either way. It can cause symptoms, systemic, or it can be localized or nothing. So I would go back to the history. What is it? Is it an air allergen? Is it something ingested? Is it something contact? And go back to that before I started to tell the patient to avoid or what measures to take. Because if we give patients a laundry list of things to do, we're taking a shotgun approach. So we need to be very precise, very specific to help them to empower the patient as much as we can. So uh, I don't know if that helped or not, but I would go back to the history so I can be very targeted and specific. What am I telling the patient? How am I educating this patient?
Next question is that says that in Western countries, the bottoms up approach is followed. That is the CRD panel first and then others. But in India, it is the top down approach. Please throw some light.
Yes, we're trying to change the direction with this evidence because when we are practicing a bottom up approach, just like that case that you gave, that I think it was the fourth case that you showed, These patients are having sensitizations, but the real question is, are they having clinical allergy? And so we're taking things from these patients, right? We're eliminating things, and we're setting them up for future allergies because we're eliminating, and then when they get re-exposed to years to come, now they truly are uh, have clinical allergy. So we're trying to change the way we think, and a lot of times our patients are coming in requesting that approach, and so we have to remind the patient we're doing some shared decision making, but let's make the best approach to this. So we're trying to change things as we speak.
So this question states that in patients with lactose intolerance, uh, can we continue curd and ghee? I think again, yes.
Yes.
Can continue.
So lactose intolerance is not a immunological; it is more of a enzyme related. And the curds, the sugar which is there has already been fermented, and ghee typically